Present after all process and my colleagues. I'm Dr. Ancha and from Madras Christian College. My case going to be is I received a picture which is a photograph of a patient, a 6-month-old male child. The informant was mother. The child presented complaints of neglect of the upper lip since birth. The child is the first born male child born out of a non-consanguineous marriage, delivered at full term. The baby cried immediately after birth. The birth weight was 2.8 kg. Soon after birth, both the parents were counseled and explained regarding the feeding techniques and corrective nature of the condition. There is no history of nasal regurgitation after respiratory tract infection, or history of frequent episodes of fever or cough, no history of difficulty in maintaining the patient, none of the congenital anomalies were reported. Developmental milestones are normal for the age, and immunization history is up to date. And clinical history, the mother is she was planning for pregnancy, she had taken iron and folic acid supplementation, no other history of any other drug intake, and there was no history of exposure to radiation or any treatment for infection during the antenatal period. She doesn't have any habits. There is no family history. On general examination, the child was active playful, the weight is 7 kg, there is no pallor. Systemic examination is found to be normal. Local examination. There is a discontinuity of the lip, the nasal floor, and the alveolus on the left side. On the examination of the lip, the discontinuity of the lip, the white roll on the left side. The apex of the cupid bow is found to be raised on the left side. The lip height is reduced on the left side. The sinus band is seen just beneath the root of the cleft, just below the proposed nasal floor. Examination of the nose. There is a discontinuity on the left side nasal floor. There is an absent nasal sill. There is a wide and horizontally placed nostril on the left side. The hemicolumella on the left side, which is the left side, is short. On the left side, the ala is found to be depressed, and there is flattening of the ala and elongation of the ala cartilages. The medial crest is found to lie a little lower than the normal side ala cartilage. The lateral crest is found to be stretched out as an oblique angle, giving the ala and flattened and stretched out appearance. The dome is found to be retrocast. The alar rim is seen overhanging the nostril. The base is shifted laterally and down inferiorly. The soft triangle is depressed, and the tip is deviated towards the north-left side. The discontinuity in the alveolus is seen on this in this view of the photograph is seen. The alveolar arch looks collapsed from the picture. The left segment looks a little lower than the north-left side. Palate, according to the history given, is normal. My diagnosis is a left side complete cleft lip with nasal deformity without any syndromic association. According to CPD classification, it's a group 1A SB with a sinus band on the left side.
Is there any photograph looking
These were the ones given. Okay, sir.
This is the entire edge of the palate.
Okay, sir.
Simnard band is autocutaneous bridge between the alar base and the collar. So that you will see that Simnard band when it presents, it looks as if it's only the cleft lip. There is no cleft behind.
Yes, sir.
And clinically we say there is a Simnard band, there will be cleft behind as well as cleft in front of it. This is the entire edge of the palate it goes. You understand it?
Yes, it's really good photograph, that means that we managed to catch it at the right spot.
I'll have to correct my diagnosis as group 1A on the left side, complete cleft. So the plan of management for my patient will be it's a multidisciplinary approach along with our being a surgeon. We also have to get a pediatrician opinion to rule out any chest infection before the time of surgery, and ENT surgeon's opinion to rule out any ear infection. And I'll do a routine investigation for anesthetic fitness. I'll also counsel them about the need for future surgeries as the child grows into adolescence and adulthood, which might or might not require different rhinoplasty or alveolar bone grafting at an appropriate age, 7 to 9 years of age.
Why speech therapy?
Just go back.
So,
Why speech therapy?
if there's it's regarding speech, generally in a cleft lip patient, there shouldn't be a problem with speech,
So
sir.
don't put in something which you...
Okay, sir.
Because then you
Label, yes, sir.
Even the first line,
Yes, sir.
multidisciplinary, this is cleft lip and areolas. This is not cleft palate.
And, yes, sir.
These are two different situations. We have got cleft lip only, or cleft lip with palate, or palate isolated. These are three different situations. If you have got cleft lip, it is only one side anyway.
Yes, sir.
But lip repair and nose correction primarily. Maybe maximum you will require bone graft later or angular correction later. But immediately opinion is not necessary. Speech therapy, need for speech therapy, no requirement.
Yes, sir.
Then,
Okay, at what age you operate?
Our center operates around 6 months of age, sir. Within 3 to 6 months we've been told, but there's told where where there's a rule of 10 where we see the hemoglobin is at least 10 gram per cent, the baby's weight is at least 10 pounds, and at least within weeks of age is needed before we intervene, and the total count and time of procedure should be less than 10%. So that also I would like to take into consideration. My plan for this patient is enhanced rotation advance with giving plastic.
What are your aims?
The aim in cleft lip surgery is to bring about the continuity of the asymmetry of the cupid's bow and the vermilion, and also to reconstruct the nasal floor.
what are the principles of cleft lip repair?
It has both the lip repair and the nasal floor repair in a complete lip, sir. So we have to reconstruct the white roll, the vermilion, and the nasal floor repair has to be done.
We'll ask about
Anything about the muscle?
Yes, sir, muscle approximation, muscle approximation should be brought about so that the vermilion symmetry
How will you
is.
bring the muscle up? What are things you do on table?
In cleft, the anatomy of the muscle, orientation of the muscle has been changed. So the muscle insertions are around the columnar base and the alar base. So those have to be mobilized to raise the flaps. So that will bring about the adequate dissection of the alar base, and the columnar base will dissect out the muscles from there. So that will bring about mobilization of muscles. So the muscle approximation should be without any tension, so that.
what are the Stephenson's principles of lip repair? Have you heard of this?
Yes, sir.
Five principles.
Fine, so talks about the white roll approximation, the cupid's bow to be, so the symmetry of the cupid's bow to be there. The again nasal floor and muscle repair also he says about, and one more.
We have not talked about, that was the mistake of Stephenson, that he did
He
not
did
talk
not
about
know.
the cupid's bow and white line and
White line.
vermilion. That was added by Musgrave later
Muscle,
on.
yes, sir.
So these are the principles of,
Reconstruction.
so collectively all of them describe principles, but you must remember Stephenson's and Musgrave.
What type of anesthesia you give?
So it's a general, child operated under general anesthesia, sir.
With what type of intubation?
It's a ventricular intubation through a south-facing endotracheal tube, which is the rate tube which we generally use, so that it is away from the field of surgery.
And in the middle.
And yes, sir.
That is important.
Yes, sir.
So what are all the points you want?
Yes, ma'am. So the points which are there, the rotation flap points, so to mark the flaps, we need the point first. So the lowest point on the non-cleft side, which we're seeing here, becomes the
Sorry, this is the...
non-cleft side.
This is...
That is the midpoint.
The subnasal is a midpoint, so that gives the effects of the cupid's bow, the cupid's bow trying to reconstruct. So from the highest point on the other side from the peak of the cupid's bow. So this distance is measured and it transports medially, which gives us the proposed peak of the cupid's bow which we are trying to construct on the cleft side. That will be the peak of cupid's bow on the cleft side which comes here. So these 3 points are marked.
So what's the fundamental problem with Cupid's bow in the cleft lip, which you want to correct at the end of your surgery?
It has to be at the same level, sir. It has actually gotten, this point and this point has to be at the same level. So it's raised here, that is what we are trying to do. And this point which I marked on the lateral side, is the lateral point, which is marked, which can be marked by various ways. Here, we have to take in a measurement between the peak of the cupid's bow from here to the commissure, which can be transposed to here. That will give us a lateral point on the left side. So otherwise we can where the white line fades, where the white line starts fading, or where the vermilion is the thickest over there, or there is another procedure is where we can from the base of the columella to that point. This measurement can be taken and transposed here, so that will again give us the lateral point on that side.
What technique is this?
So
What technique is this?
this Millard's rotation advancement that we look at. So
Is there any change in this technique?
modification, sir. Actually, this technique was modified by various other surgery. Molars modification was given where the Millard's here, the rotation of this the flap is at the columella-labial junction. It doesn't cross that. In a molar's flap, it goes into the base of the columella, and the bracket is given just after crossing the columella-labial junction in the columella. So that gives more amount of tissue for us to incorporate. So that is one of the modifications, the molar's modification. And another modification.
Do you commit the advancement plan?
So
In recent modification, what Dr. Karuna is saying,
Yes, sir.
do you commit on the advancement plan which is marked here primarily?
Is that point fixed, point A, or you can shift it?
we can shift it. If the lateral element is going to become this small for us, it won't be short, then we can shift this point can be shifted a little.
Talking about the
this-
upper incision.
upper.
Are you commit
Horizontal.
primarily horizontal guide incision or later on?
I don't get the-
What she's trying to say
Yes.
is from where you start
Start
going horizontally, do you want to commit that point or when you
Primarily or
Yeah.
you want to
Cut as you go.
cut
I
as
cut
you
as we go, so that it is in according to adequacy we can it should be done. That's why it's called cut as we
What other technique you know?
go. Aside from Millard's.
How are you going to correct the nostril flow?
Sir, while doing the Millard's rotation advancement only, we'll have, because after raising the C flap, we'll have access through for the columella through this point and for the alar base through this point. So we can do nasal flows, sir. Oh, sorry, sir. Nasal flow can be repaired through Omarine flap and mucoperiostal flap from the lateral side. Can be done.
In this case,
Woman is normal.
Woman is
Woman is
Almost
normal.
normal in this patient.
Are you going to discard the mucosa flaps?
No, sir. These flaps can be transposed and we can use it on the medial side and the lateral side. So that will again give us a nasal
N flap and L
L
flap.
flap can be
Don't
used for
discard
nasal
anything.
flow.
You can
Yes,
use
sir.
it.
Nasal flow condition.
Why you want to keep it there? Use it. What is the advantage?
Of keeping the flaps.
Mucosa flaps there, adequate amount of tissue
We don't
there.
want a micronostril at the end of the process.
That is one.
By advancing it can become smaller.
That is second.
Yes, sir. And the fistula again.
That is third. Does this patient is going to require alveolar bone grafting? You said that there is
yes,
a
sir.
gap in
Where
alveolar.
yes, sir. So that
You require some amount of tissue during your alveolar bone grafting.
yes, sir.
Keep it, don't discard anything. In a primary lip repair, try to keep the tissue in that area. So in near future when you require alveolar bone grafting, you have got adequate tissue. Anyway, how you repaired the mucosa, repaired the L flap, M flap, how are you going to narrow
The nostril.
the nostril? And what that the newer coordinate?
So we can do while doing this only we can do a primary angioplasty. It can be done around that is
We are talking about the nostril.
Elar
and the
cell
Elar base. How
cell
your
sutures.
Elar
Cell
cells-
sutures can be taken from here to here, so that will come across and hold the Ila, the proposed site.
Go from the columella or go on to the opposite side also to get a symmetry.
Opposite is the septum.
Opposite end.
I'm not sure about the opposite. I thought it's done to the septum and it's brought back so that it comes to the midline.
Go to the opposite side, so the opposite ela also get the stability for the symmetry both.
Yes.
The ela since comes out from the opposite side, comes again in the midline and then take a bite on the affected ela and then bring it together so that it will be symmetrical alignment.
Yes.
Okay. So this ela since has to be taken before your muscle repair. Okay. So what you will do to bring the columella, the cupids go down? What are the things you will do it to bring that columella? Once you have shown that is a skin incident.
Yeah, this is skin incision, so muscle has to be released from the
Okay.
columella view. That again has to be done.
And what is there at the ila nasal spine, which is still holding that your lip on there?
Septus minus ligament.
Yes,
That
they
has to
say
be-
no. Why you are allowing the examiner to
That
ask?
also has to be.
You have to tell upfront. You have to tell that I would like to release that
So
particular.
that it is moved down.
Unless you release that, that is not going to come down.
Yes.
Okay. You have to release the muscle as far as possible. Don't cross the midline. Okay.
Yes.
What will you do today? Do we need to do something with the septum also?
Yes, the septum was deviated to the non-cleft side. Having released the septospinous ligament, we'll have to release the septum from beneath. That can be accessed through the incisions you've already, the flaps you've already raised. So because it is deviated, we have to make it straight. So there might be an excess of septum in the inferior margin, so that can be trimmed. And we can also straighten it out by scoring it on the non-cleft side. So parting we do so it becomes straight. The concavity becomes straight. That can be
Since it is
done.
only cleft lip, you may not require so much of procedure, but if it is cleft lip and palate and
Now
clear
we
variation
require-
is there, then you
For stabilization of the septum and the midline.
you require the
This will prevent the further deviation and obstruction.
Yes.
Suppose you have done all things, you release the muscle, you have a septospinous ligament, antenna, rotation flap, and you have sutured all the layers, sutured the white roll.
Yes, sir.
Still you find that the people were still peaking. What you will do?
peaking means you
It's still
understood.
it's still higher.
Right. Shortly is there.
What can be done? Any procedure where you can bring it down?
So it can
You can release it just above the white roll, you release it, create a triangular defect and insert that amount of triangle in the lateral element.
In plastic surgery, if something is short, put as a plastic or back cut, you will be able to get it.
So Z-plastic answer was not wrong.
Yes.
What you will do for aligning the white roll and the red mucosa, white mucosa? Require no? Alignment of those points.
Yes, sir.
What you will do in the vermilion?
There are flap described. I have not seen it done, sir, but there are flap described which can be done on the dry vermilion. You can take a triangular flap on dry vermilion and incorporate it here so that the symmetry of the thickness is the same on either side of it.
There are 2-3 modifications.
Yes, sir.
First modification done by Dr. Nurov. Second modification done by Dr. Rajesh Pawar from Telangana. Anything you do for the nose primarily?
We can dissect out the ila cartilage and the ila sutures can be done.
And? What is-
Interdermal sutures.
What it called as?
Interdermal sutures.
What it is called?
Like,
ATS.
ila transfixation sutures can be done so that there is.
Okay. Next.
Thank you.
That's all right.
Yeah.
Enough.
Well done.
Enough for today.
Yes. Nodos.
Very well.
Vermilion triangular flap is nodos.
No, on the lateral element.
Yes.
Very good. Very nice.
Very good. Your confidence is very good and your
Yes.
knowledge is good and that is to be commended.
Yes.
And
If you
you
prepare and come like this,
You speak as if you are already operated.
Yes, really good.
Have you finished operating on this baby? This baby has been operated?
This was, I have pictures.
Yeah, that's what I want to
This was
This is understood.
This was not Tata setup, sir. This was the one which is given me. This is
She knows the stuff.
She knows the stuff.
This is just my diagrammatic representation of the same.
Let's see it.
Yes.
Oh, very good.
Keep it up.
Really good. Depicts all the muscle dissection.
Very
And cartilage dissection, I think the second cartilage dissection repositioning. Other the muscles which I couldn't get it right. Z-plasty, the mucosa within discrepancy, the final scar. This is another case which, again a similar case of, similar patient on the left side, complete left. This, I don't have steps, so pictures of the steps now, but I can show you the post-op, the final picture.
Good.
This is again another case on the right side, post-op. So second diagrammatic presentation of same. Post-op surgery. I just wanted to, Madam had asked me to put if I had a picture of annular bone grafting. So this was done in a bilateral cleft patient. The child was 8 years old. This is the annular bone defect which is seen over here, the yellow marking, that's the harvested bone graft. After packing the bone in the alveolus, and that's after suturing the mucosal flap. This is on the same patient, but on the left side, the grafting was done 3 months back. The healed annular bone graft is seen.
Okay. Thank you.
The importance of drawing, that should be
I
emphasized.
she's also understood well because she's trying to draw and understand.
Yeah, that
She's
makes
understood
it-
everything that was happening.
I
Nice.
see that bone graft which was harvested.
Yes, sir.
It is particle as well.
Yes,
The
sir.
particle piece is there.
Yes, sir. They exhibit for the
You
nasal floor.
not to use that particle piece.
You can use particle bone in the area of your